On to our next talk for today. This is going to be by Dr. Alexander Thomas. Dr. Alex could not join us in person, but we will be definitely running his very valuable video today. He's going to talk to us about beyond accreditation towards evidence-based practice and grading of
inviting
hospitals.
me to speak on this occasion. The theme of
Dr. Alex is the founder president of AHPI and a patron at CAHO. He has co-authored the book on a handbook of quality along with Dr. Gnani, which is a wonderful, wonderful book. I would recommend everybody to read that book. And he's the winner of the Emeritus Teachers Award in 2014. So let's start playing the video of Dr. Alex and listen to what he has to say about grading of hospitals beyond accreditation.
I bring greetings to all of you on the occasion of the World Accreditation Day, and I want to thank you for inviting me to speak on this occasion. The theme of today's talk is Accreditation, Empowering Tomorrow and Shaping the Future, and I will be talking to you on beyond accreditation towards excellence, the grading of hospitals, a process which the Quality Council of India has initiated more than a year ago. If today, when we talk about grading, I think the first thing that will come to our mind is these sort of rankings done by popular magazines and newspapers. Some of the other institutions which do grading are Brickwork, CRISIL, India Rating and Research, ICRA, Carriage, and Acute Rating and Research. But I think it should be noted that here they look at financial parameters of resources, efficiency, safety, patient care, equity, clinical excellence, and timeliness. These are the parameters that they use. There is no patient-centric grading that focuses on patient services, patient care, and patient experience. Looking at the global scenario, again, we have quite a few institutions which do grading. The CMS, Center for Medical and Medicaid Services, US News, Leapfrog, Health Grades, and also Rush University, among others. A very quick snapshot of these. I think in each of these, the QCI has done extensive research. Some of them miss crucial parameters. Some of them have limited data and few elective procedures. Some of them have questionable voluntary self-reported data. And in some cases, there is lack of transparency in the methodology, which is very crucial. So just coming back to NABH, all of us have heard about NABH. It's been in existence for more than a decade, and we all know that it has made a huge impact on patient care and patient safety and quality of healthcare delivered in the country. Apart from the assurance of quality and patient safety, it helps in empanelment. It also encourages education and training for quality and patient safety, information, education, and communication activities. It endorses various healthcare courses. It helps in medical tourism, and also is used extensively by the insurance industry and by government schemes to ensure that there is a basic patient safety framework. Now, what is the difference between NABH accreditation and the grading that I'm talking about? NABH is done by the National Accreditation Board of Hospitals, which is a constituent of the Quality Council of India. Grading is done directly by the Quality Council of India. NABH is very much involved in the process of the grading exercise, which we have been involved with over the last year. The objective of NABH, all of you know, is it creates a level playing field for all healthcare facilities adhering to certain basic quality standards, whereas grading will generate a grading system and grade hospitals on their overall performance or on the basis of excellence in certain medical procedures. The indicators in NABH is the 6th edition, which is ready to be released, whereas in grading, we have patient-centric verticals and key performance indicators. The role of grading: it uses a logical and scientific approach, enables selection of suitable and appropriate healthcare entities, enhances visibility and credibility of healthcare entities, and also attracts better medical professionals to the hospitals. Now, this is a very crowded slide, but through all this, there is one factor which shines out. The benefits of grading will be focused on the patient. There are other advantages also. It helps the hospitals and clinics. It helps the healthcare organizations to benchmark their operations to that of their peers. It definitely will help again the patient in the medical tourism industry. It will also encourage physicians, nurses, and other staff to choose a healthcare provider which has achieved clinical excellence. People who want to donate or NGOs, they could choose the right healthcare institutions to make their contributions. Insurance will find this very, very valuable to contract differential prices among healthcare providers. And as is being done in NABH, municipal, state, and central governments could use hospital grading to directly access the institutions under their authority. But central to this is the patient. The patient could choose the right hospital, clinic, diagnostic lab, and imaging centers that deliver high quality of care and patient safety. Now, I'll just look at the objective and the outcome of grading. The objective is to educate and encourage our patients toward, while choosing a hospital, also incentivizes the hospital towards prioritizing patient safety measures and developing a healthy competitive environment among healthcare facilities based on the grading parameters. Outcome, which is very important, it assists patients to make informed decisions while availing healthcare facilities and improves the competitiveness among healthcare facilities, which will enhance the ambit of their service along with upscaling patient experience, ultimately leading to patient satisfaction, which is at the core of our efforts. This is a QCI initiative, and I must compliment the Quality Council of India, and especially Dr. Narottam Puri, for leading this exercise. So how is the process? The Quality Council of India formed a technical committee. This technical committee had the eminent quality experts in health in the country and also very prominent clinicians from different parts, from different fields in this committee. So the first thing that the technical committee did was to get inputs from stakeholders. We got inputs from patients, we got inputs from IMA, from AHPI, from CAHO, from ANBAI, and from other experts across the country. And after that, we started the work of creating the standards and then went on to the review process. Now, the creation of the standards took the majority of our time. The technical committee met regularly, almost every week, spent long hours in deciding the standards, deciding the allocation to each of them. And finally, we were able to agree with inputs from experts that these were the 10 verticals with the weightage, the structure, the process, the outcomes. Patient experience, you may wonder why it is only 5%. One of the reasons is it is sometimes difficult to get the actual data from patients. So we have incorporated the patient experience in each of the verticals, be it process, be outcome, etc. Clinical governance and risk identification, risk mitigation, sustainability. And again, here, I think this is one of the things which is a little different. We have laid great stress on sustainability and on protection of the environment and how hospitals could be part of the effort towards improving the environment and mitigating during disaster times, academics and research, staff experience, and use of technology. The review process was also equally stringent. The first draft was sent to the steering committee, to experts across the country. We got their feedback, we modified the document, and a very important next step was getting the assessors' inputs. This was circulated among leading assessors, and we had a full-day workshop where their inputs were given to us. The next important step was to have pilot projects. We had pilot projects in 7 hospitals, and we got very valuable inputs from these hospitals. And at this time, I must appreciate the assessors and the hospitals for the meticulous way in which they went through the document and gave us such valuable information that we were able to incorporate into the final document. Here are some of the events, physical meetings. We probably had about 4 or 5 physical meetings in Delhi. We had umpteen virtual meetings. This is one of our technical committee meetings in Delhi, and you can see Dr. Atul Kochar from NABH. You can see many of our colleagues from CAHO, from HPI, and from other organizations. And in the group among SSers, it's actually virtually a who's who of the top SSers in the country. And we're very grateful to them and to the hospitals. This is a photo taken at CMC, but we had a similar process, a very encouraging and a very useful pilot in 6 other hospitals. Now, the plan of the Quality Council of India is that we are in phase 1. The document will be finalized over the next few weeks, and we plan to do it in hospitals. And parallelly, we are also working, the Quality Council is also working with centers of excellence. We are looking at the lab, at radiology, at oncology, and a few other areas. That is work in progress. Phase 2 is when we'll be looking at clinics and district hospitals, and phase 3 when we will actually go down to the ground, the primary health centers and the CHCs in the country. Now, the process of this inspection for grading is also more or less been finalized. It'll be a combined desktop and physical assessment, where we hope to get most of the information on desktop assessment, and then the physical assessment will be done by the assessors on site. The duration of the grading, the process, once it is given, and other factors are being worked out as we speak. The assessors also are being trained now. The assessors for the grading will be a different set of assessors who will be oriented specifically for grading of hospitals. And here again, we have come out with certain criteria and also a training manual for them. In the document that we are preparing, we also have a guidebook. This is mainly for the hospitals to help them, as this is the first exercise in the country. That they will have many questions, and we hope that this guidebook will add value to the standards that we are coming out with. The launch is expected in a month or 2, because there's still some work to be done, and as we fine-tune it, we hope to launch this probably by end of August. And after that, we plan to roll it out in the country early next year. Of course, as all of you know, it is a continuous process, and hopefully it will develop into a robust, globally acclaimed system. So on concluding, once again, I want to thank you for giving me this opportunity, and let us, in celebrating World Accreditation Day, let us continue to uphold the highest standards of care and excellence for our patients. They are central to our existence and to our profession, and let us ensure a healthier and safer future for all. Thank you very much.
Thank you, Dr. Alex. I think it was a wonderful talk by Dr. Alex on the grading system for accreditation. And I think it's very simple that, keep your eyes on the prize. And the prize is your patient, the patient satisfaction. So thanks a lot. And with